Welcome everyone to the inaugural Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. I'm your host, Bruce Hall, and before we begin, I'd like to go over a few disclosures. First, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corp. And Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this slide. Now it's my extreme pleasure to introduce our first guest in this series, Dr. Craig Russin. Dr. Russin is an associate professor at Baylor College of Medicine and Texas Children's Hospital. He's an adjunct professor of computational applied math at Rice University, and he's the CTO and co-founder of Medical Informatics Corp. Dr. Russin will be discussing how he is using data to predict deterioration events before they happen in pediatric patients with a high risk of critical deterioration. How are you doing today, Craig?
I'm doing well. How are you doing, Bruce?
I'm doing very well. Thanks for helping us kick off this series. And let's talk a little bit about our format, Craig. I'm going to start by asking you some questions to give you the chance to present your study to our audience members. And the audience will be muted during this time, but the audience can ask questions as we go along through the Q&A tab, and you should see a Q&A tab as part of the Zoom link here. And at the end, we'll address as many questions as we have time for, and all the questions that we get will be answered in written form and distributed after the session. Sound good?
Sounds great.
Okay, so let's kick things off, and let's start by discussing your study. Can you tell us a little bit about the population that inspired the study and what was the motivation behind the study?
Yeah, so in my lab at Texas Children's, which is the predictive analytics lab, we focus on building new metrics of health from physiologic data being generated by patients. And so one of the kind of critical populations that we were looking at is what's called a single ventricle population. And so this is children that are at rather extreme risk of having sudden cardiorespiratory deterioration events early in their lives. And unfortunately, it's often very difficult to predict these events. Even if these are very complex cases, they're very complex physiologies, and it's just hard, right? And so what we tried to do was we tried to say, we tried to find out if there is a physiologic fingerprint that occurs just prior to when these children deteriorate. And we used machine learning and data in order to do this. And so the idea is that we can take the traditional monitoring that's kind of done with these patients, measuring the ECGs and the blood pressure waveforms and other various vital signs that are generally used to monitor kind of the moment-to-moment status of these patients. And we want to be able to then provide, or at least interpret this data automatically, to provide a quantitative measure of how likely a cardiorespiratory deterioration event would be in the next 1 to 2 hours.
Boy, so pediatric patients, and interesting to hear all the data you're looking to collect to predict these events. Let's talk about conducting the study itself. What was the process and some of the methods you used to collect this data and support this research?
Great question. Thank you. So obviously, it's a data science study. And like any data science study, you need to have a rather substantial amount of data. In our case, we wanted to look at the quantitative data that was being generated by patient monitoring equipment. And because these kids can be kind of in different units of the hospital, in different beds, and they can move from bed to bed, we had to record basically everything from all patients in the units where they could be. And obviously, this isn't something that you can do when you're just rolling a cart around. Logistically, that would be very hard. And so what we used is we used the sick-based software from Medical Informatics, obviously, in order to do that. And so between January 1, 2013 and February 1, 2019, we recorded approximately 900,000 hours of data just from patients that met our inclusion criteria. And if you think about that for a second, if you put that number in context and you do the math, you as a individual would have to stare at a bedside monitor for for 101 years continuously in order to actually just observe that amount of data. So that's kind of the scale that we're talking about. And that was only, 200 patients, right? Or 200 some odd patients. But that was the data set that we started with. Then what we layered on top of that was a chart review to identify all of the times where cardiorespiratory deterioration events occurred in this population. And so that meant that we had to define what we meant by cardiorespiratory deterioration. And so what we said was that these events are either an arrest requiring CPR or some sort of unplanned intubation event. So we have, cardiac arrest, and we kind of have a respiratory arrest. And so we found the dates of surgeries that these kids go through, because there's a specific kind of start and stop time where these children are most likely to have these sorts of deterioration events. And then we found all of the events that happened during that time frame. And then basically what we did was we constructed a logistic regression model that teased out different features of the waveform and vital sign data, and then combined them in such a way to establish a new metric that was predictive of when these events occurred, right? And so this metric could be calculated in real time, directly from the data that's being generated by the monitors. And obviously, we use SickBay in order to actually develop, to do all of the data transformation, as well as to do the logistic regression modeling on the data set that was generated.
Well, that's all very interesting, but you had me at 6 years and 900,000 hours of data, and that we'd have to stare at a screen for 100 years to collect all this data. Really, truly remarkable. Just the sheer weight of the data set is incredible. Let's talk a little bit about your findings now, if we could. Did you get the results you expected? Was there anything that you found that was unexpected?
So can we advance to the next slide? So this was a larger study of a previous pilot study that was done several years ago on a much smaller cohort. So we suspected that there was this indication we suspected that it existed, but at the time we didn't have enough observations in order to demonstrate the performance that we needed, and we couldn't validate because we didn't have enough data. Now we have this larger data set. We were able to redo the analysis and split the data up 50-50 between test and validation. And what we were able to establish is that it turns out that between 62 and 74% of all of the cardiorespiratory deterioration events that were observed in our population could be predicted by our algorithm 1 to 2 hours in advance. And I say those numbers because there will always be events that you can't predict, like if a patient throws a clot or something like that. Those are fundamentally unpredictable. So we're not shooting for perfect here. What we're shooting for is what is the benefit that the algorithm could provide, and then what is the cost of that, right? And the cost in this case is the introduction of alerts into the care environment. And so, for a long period of time, there was this issue of alarm fatigue, where they're just flooding the care staff with all of these alarms that were just basically nuisance alarms. And if you look at these particular cases, right, the typical alarm loads that you see, or the number of alarms that are generated by these patients is, hundreds of alerts per patient per day. And, mostly SpO2 alerts, either high or low, or heart rate high or low alarms, right? So the basic bread and butter stuff, that's like 80% of all the alarms. But what we're talking about here is that we can adjust this threshold for detecting these events, and if you pick a threshold, somewhere between 2 and 4, given what we've observed, then that's going to introduce between 1 and 3 alarms per patient per day. And obviously, if you make the algorithm more sensitive, you get a higher alerting rate, but also you introduce, congruently more alarms into the environment. And so it's really a question of, what's the cost, what's the trade-off, right? What's the balance of, the benefit of getting these kind of alerts versus the effort that's required in order to respond to that kind of 1 to 3 alerts per patient per day level. But what that means is that if you introduce those alarms into the environment, basically between 2/3 and 3/4 of all arrest events or all cardiorespiratory deterioration events, you will respond to 1 to 2 hours in advance, which I think is a huge thing.
That's really remarkable and very interesting to hear you talk about the trade-offs between the number of alarms that practitioners have to respond to and the accuracy and predictability of these events.
Indeed. And so if we go on the next slide, what we can see is some renderings of what this alert kind of looks like over time. And so this is an example of a respiratory deterioration event that was recorded. And what you can see is the heart rate, the SpO2, and the respiratory rate, common vital signs over the 3 hours prior to a respiratory deterioration event that happens at t = 0. And what you can see in the bottom graph is the risk index that's being generated by our algorithm continuously. And so you can see, a little bit before t = -1, the risk index exceeds 10, which certainly, meets our threshold of, 3 to 4. And that would have generated an alert at that time, right? So this patient would have literally alerted, the algorithm on this patient would have alerted, more than 1 hour in advance of when this respiratory event happened. And what's interesting, if you go to the next slide, is that the cardiac events seem to be more predictable than the respiratory deterioration events. So this is an example of a cardiac arrest that we observed, and obviously that happened a little bit before t = 0. But what's fascinating about this, and we think that's due to the subjectivity of the difference in subjectivity between a cardiac arrest and a respiratory arrest. Cardiac arrests are just easier they're less subjective, let's put it that way. And that's probably factoring into to the performance of the algorithm. But in this particular case, you see that, the risk index clearly goes up, at least a half hour before, or at least, a half hour before t = 0. But what's striking is that, if you look at the scale, right, this patient had a risk index above 10 for almost 3 hours, right? And so more than 3 hours would have passed before our algorithm would have alerted that this patient was going to have an arrest momentarily, right? And so I think that I think this has the huge potential of providing another level of surveillance that is tailored to the specific risk that these kids have, that isn't necessarily baked into the general monitoring infrastructure of a hospital.
For those folks just joining us, you're looking at the Healthcare Data Matters webinar. We're talking with Dr. Craig Russin, who's presenting his study on predicting deterioration events in pediatric patients. This is some wonderful information and some amazing results, Craig, in your ability to predict these events. Can you tell us what's next? Are you planning to do any future work for this study? Are there any other studies in the pediatric cardiology arena that you're thinking about, and basically what's coming up for you?
Yeah, so if we go on the next slide. So now what's happening is that we actually have the NIH is supporting us in a multi-center trial in order to validate this algorithm, because obviously up until this point we've only been using data from one site, and other sites may have different practice patterns that could technically affect the performance of the algorithm. So we need to validate it across different sites in order to demonstrate safety and effectiveness. But the idea is that once we get that algorithm validated, then we can start moving this to the next level and potentially even creating a virtual monitor that can be instantiated to watch over patients using sickbay. And so this is an example of the monitor that we actually created. This is, a website that just gets that gets automatically added to the patient when they have specific risk factors associated with the application of the monitor. And you can see the first line is the arrest index, and then all the other information is kind of supporting information that that a provider would need in order to figure out what's going on and how to react, or how to intercede. And so the nice thing about this, though, is that it's one of those things that it kind of changes the nature of monitoring. We don't necessarily think about monitoring in terms of software, right? We always think about monitoring in terms of the physical boxes that are sitting at the bedside. The problem with that is that if you have to build a box for every algorithm that's going to come out there to watch over a patient, you're going to flood the. You'll never have enough space in the bed. Right? You'll stack them up, 6 foot tall in the ICU bed. And so, by moving from a hardware-based monitoring approach to a more software-based monitoring approach, still having access to all the alerting, and obviously you can see the text message that was generated by this monitor to the care team on their endpoint device. So you still have all the alerting and all the oversight, but you don't have any of the physical hardware infrastructure that you need to take care of, and so that makes it scalable, right? So instead of having to buy 50 different monitors for 50 different cases, you can simply buy the software that enables it and then essentially process all the data. It's much easier to scale and maintain when you kind of take that software-based approach.
Very interesting. And once again, this is a browser-based interface, right, that we're looking at.
Exactly, and that's what's really cool about it, because it's a website, you can access it from any device. And so I always thought it was odd. So I'm an engineer, right? I want my computers to work for me, right? If there's a piece of data that gets generated, I want that data brought to me. I don't want to have a physical mail. You have to go to the mailbox to get your mail. Email, it comes to you, right? And so it's 2020. We have to have our data coming to us. We have to make the machines work for us, and not the other way around. And so when you talk about that in terms of monitoring, right? What that means is that, for example, that text message that you see, that text message can have a URL embedded in it, so that you click on it, you literally get brought to, or the monitor gets brought to you and visualized wherever you are. And so what that means is that you're more effectively using the technology that you have in place in order to take better care of patients.
I keep reminding my wife that the technology is supposed to work for her, but she still feels a little bit dominated by it. So it's interesting how very interesting this is. And boy, this is some wonderful information, Dr. Russ, and truly incredible work you and your colleagues are doing in the area of pediatric cardiology. At this point, I see we have a number of questions that have come in from audience attendees. I'm now going to turn it over to Rajin Patel, who is MIC's Director of Research, to help moderate and facilitate those questions. Raj, are you there?
Hi, Bruce. Can you hear me?
Yes, I can.
Great. Yes, I'm here to answer, or rather ask questions to Craig. As you see on the screen, there's a couple of steps. If you'd like to ask questions, feel free. We already have a couple up. So Craig, if you will, can you expand a little bit on externally validating your algorithm? In particular, you've mentioned the multi-center study. What does that collaboration look like? And if people are interested in getting more information, how do they go about getting it?
Yeah, so basically what that looks like is that we have a kind of common data collection infrastructure set up on all of our sites. And that infrastructure obviously is sickbay, because that's what we're using to normalize all the data. And what that means is that we're kind of testing two things. That number one, that the equipment at different sites are doing the same thing. So some sites are Philips, some sites are GE, and clearly we don't want to have to recode the algorithm for different kind of infrastructure that could be at any particular site. And so that's why we use the sickbay system. And then what we do is, obviously there are, like I said, there are different practice patterns and different ways of doing things at different sites. And so as a result, we need to make sure that the algorithm, works across those patterns. So if we have people that are interested in it, feel free to please contact me directly. Maybe there's a way, Raj and Heather, that we can go and send out a contact sheet if people want to get more information and contact me directly at my Baylor address. I think that would probably be the best way of doing it.
Yeah, that sounds fine. Yeah, let's see if we can get those contacts for you for folks who might be interested in collaborating. All right.
Absolutely. And there are a number of other studies that are coming down the pike too. So I'm always happy to make new friends and get introduced to new collaborators.
Okay, that sounds good. Yeah, more data, better algorithms, right?
Exactly.
Okay, I've got a couple more questions. For this study, what were the hardest variables that you needed to obtain, and how did you get those variables?
So that's interesting. I think so there were 6 variables, or 6 or 7 variables that that were important. Clearly, heart rate, SpO2, the common ones, are there. Heart rate variability is a common variable, but it's actually not necessarily calculated by the monitoring equipment themselves. Not all vendors do it, and so generally, what we would have to do is go back to the waveform data and calculate it ourselves. And so we have different algorithms that implement those steps, but it meant also recording all of the waveform data include, which is about 10x or 20x times the size of vital sign data, because it's coming across at 240 hertz instead of 0.5 hertz. So just from the kind of sheer storage capacity, those were a little bit challenging. But I would say the most difficult parameter that we had to get was actually what's called pulse pressure variation across the respiratory cycle. And that's important because it measures, how your cardiac output changes as a function of the preload state of your heart, which obviously is important for this population. And so we also found it was one of the more predictive, one of the highest weighted factors of the algorithm. But in order to do that, you have to do it on a patient that's not ventilated and relatively small. And there are necessarily algorithms to do that. And so actually my lab has published another paper on how to analyze the pulse pressure, how to get pulse pressure variation from an SpO2 plus from an unintubated, non-ventilated infant. And so we actually used that algorithm as an input to our regression model. But there's an entire year of research that went into just that one factor to do all of the signal processing that was required to make that work. But when it worked, it was very influential, and so we're really happy to have it.
That is really cool. Deriving new signals, right, from the data. A question came in that's sort of a follow-up, and forgive me if I get these variables wrong, but the question is, have you looked at cross-correlation between HRSD and SAT-SD? And my assumption here is that HRSD means the standard deviation of the heart rates, and SAT-SD is maybe the standard deviation of oxygen saturation. I'm going to assume that that's the case, but yeah.
Yeah, I think that's a good assumption, because that's the way I would interpret it. And the answer is we hadn't looked at it, but that's a great idea. And it's something that if somebody has interest, I would be happy to collaborate on, because I think that is a great idea.
Great. Very good. So that's exciting, right? Getting more ideas for more inputs into the algorithm, possibly, and some collaborations.
Exactly. The interesting thing about this is that there are a lot of parameters that have been studied and trapped in journals, like trapped in journal articles, because there's not really a mechanism to make use of them kind of at scale. And that's what I really like doing. I really like, taking all of this information, all this great clinical information that's already known, and then making an algorithm out of it in order to automate the process, right? Because automation is efficient, and automation, it just provides another level of oversight that's important. And I think it's something that we're going to be seeing more of in the future. And so the future, I think, is more algorithms as opposed to less algorithms.
That kind of makes sense to me for sure, from what I've been seeing. So let's move to the other side of that, though. When we're talking about collaborations and getting more inputs, how are you sharing the study results with the other sites participating in these collaborations? Right. So you've talked about setting up a data structure, adding these inputs, but once you have the results, how do you share those?
So, well, the results of the study obviously are disseminated. So the study sites are going to be brought into the publication process and all of that stuff. That's the standard academic kind of process of releasing information and collaborating. So that's all good. But I think what you're more referring to is, once we have an algorithm, how do we go and ship it, right?
Yeah.
Because that's ordinarily you build a piece of hardware and you have to ship it, and they have to build a lot of hardware. But what we do here is we just create a little module based upon a standard development kit that's already in place, or that we already have. And using that kit, we can build a little module, and then we send the module over to the site, and they install it. And then that algorithm becomes a kind of research use only virtual patient monitor that can be instantiated at that site. And if we build the algorithm correctly, and if we build the kind of wrapper around it, we can make it such that it is vendor agnostic to the hardware infrastructure that each of the individual sites have. So, like I said, some sites have GE, some sites have Philips, and it's kind of craziness to be able to have a Philips-specific algorithm, a GE-specific algorithm, unless there are kind of reasons for that, and that there could be. But in this case, it's not really necessary. And so so that's how we do it. It's just compiling up a module using the SICK-based standard development kit and shipping it over and installing it.
That's very cool. So it sort of sounds like the math can go anywhere where the data is, right? And then you have a working algorithm at the patient's bedside and then remotely, sort of separated from the actual device itself.
Exactly. And it turns out it's a lot easier to ship the algorithm to where the data is than ship the data where the algorithm is.
Sure.
Yeah.
All right. I think we're going to hold a couple more seconds for questions, but we are approaching the end of the hour, so I want to be respectful of everybody's time. I was
going to say, Raj, any more questions?
No, I think we're good. Bruce, handing it back over to you.
Okay, thanks very much, Raj, and of course, Dr. Russin, wonderful research. Thanks so much. I was just fascinated by listening to the back and forth on this. And we are at the end of our time today, everyone. We'll create a follow-up document with all the questions we answered and any that might have come in that we didn't get to. We'll send that to all the attendees on the call. We'll also make available Craig's research, a replay of this webinar, and an audio podcast version that we'll edit up and make available for audio only. I would like to thank you so much for joining us in this inaugural Healthcare Data Matters webinar. We hope you can join our next session on October 20th, featuring Dr. Javier Lassa from Texas Children's Hospital, who will be discussing hemodynamic care and management of neonates. In the meantime, you can visit our website for more information or check out our associated social media channels. And I know Craig earlier mentioned contacting him. You can use these social media channels to go ahead and interact and ask questions and generally advance this whole topic of data-driven care. So thanks once again for joining us on Healthcare Data Matters. We're very grateful to have the opportunity to advance a new standard of patient-centered and data-driven care. Take care, everyone. Have a good day.